welcome everybody. So thank you for attending. We are recording this and you'll get sent the slides afterwards. Laura and I are very happy that we've got Danny today, one of the first contact physios, but also works in the pain team covering Mid, South and Basset Law. Is that right, Danny?
Exactly that. And Rushcliffe. That's South, yeah. Perfect.
So let me go through these slides. Again, we all know how to use Teams. Please use the chat if there's any questions on a different topic, but we want this to be as interactive as possible. So we will be asking questions like we have done in the other sessions. So please just speak up. Okay. And as I said, we will send the slides that will have the links, but I'll make sure I put the links in the chat as well. This is a safe space to discuss best practice, kind of how we manage in primary care. Be nice to each other. So as before, for anyone that's not met us, but I recognise most names, Laura, Brandon and myself are the NATH ambassadors for the allied health professionals working in first contact roles. So anything we can help with education development, career development, any general queries, then please contact one of us. So Laura is up in Newark and covers more mid. I'm more in the south. That's it. Anything else from you, Laura?
No, just to say hi and welcome and thank you for coming.
So just so you know, we've got the next session that we've got booked is serious spine pathologies, where we've got one of the spinal practitioners from NAZU, the spinal unit at QMC. So we'll be going over what to do in primary care, how to recognise, how to safety net and what they do in their service. So you can sign up online. And then after the conference last week, we have lots of new topics that are coming and we'll keep you updated. So today we're specifically looking at chronic and widespread pain and how to refer into the pain team, as well as what they can offer. Now, just coming into the room, we've actually got Pete Gray, who covers City Pain Team. So I'm going to put him right on the spot as he enters in. This is Pete Gray.
Oh, God.
So you have the perfect collaboration of pain team. So kind of all of Nottinghamshire, you've got knowledge of pain team services. So we'll get started. So first case. Again, if there's any additional questions you want to ask, please either just shout it out or write in the chat. So we've got a 40-year-old female, obviously a very female looking back there. Years of multi-region pain, so kind of shoulder blades, arms, legs, elbows, back, feet. Each day it's different to what hurts, works on a desk-based role and really struggling to concentrate because pain is the big problem. She's tried lots of things, cocodamol, gabapentin, previously pregabalin, amitriptyline, wants more pain relief right now because everything hurts. Does not want physio, does not want to exercise. What do you want to know? You can add on some sass too if you want.
I guess it's really important to know what she's responding like to the medications that she's currently taking, whether she's tolerating them well, whether they're helping her, whether they're making sure she gets a good night's sleep.
Previous treatment, tests complete, yeah. So to date, had inflammatory profile, which was normal. No imaging to date. Any other factors contributing to pain? So what kind of things? Other factors? Family history? Yeah, mother has fibromyalgia, so I think it's hereditary. So I think they've got that too. Anything else? Just wants medication.
Desi, I think I'd want to know, as well as pain, whether there were other symptoms with this. So thinking about widespread pain, so, you know, thinking about sleep, tiredness levels, other wider symptoms suggested of kind of nervous system sensitivity, headaches, IBS, sometimes pins and needles and numbness, bladder urgency, restless legs, like a whole range of symptoms that you could start to explore. Depends on what they're offering up. Sometimes they don't think it's relevant to offer that, but when you start delving, you might find some more information. that might help you to decide.
We've got any monitoring done before. I assume that's blood tests or inflammatory markers. So we've only had it, we'll say 6 months ago, we had inflammatory markers, but nothing's really changed symptom-wise over the years. So let me get the next one up. So again, I think we've covered most things on here. So what has led up to it? So has there been any trauma, mental or physical? Any illnesses? What is the behaviour? So is there a pattern of pain, be it through the day, do it through agonesis, neurological symptoms, exactly what Danny said, inflammatory symptoms, kind of alluding to in the chat about looking at inflammatory markers, stresses, so it can sometimes be going into work if there is a contributing factor, and that's why struggling at work, and looking at that wider system, so exactly what Danny has said. So objectively, so you've come in, she's in front of you right now. What are you going to look at? Oh, just giving it away. So let's go with the basics. And remember, in FCP land, what we normally get 15-20 minutes to assess, including the subjective. So what are the key things you want to know right there, right now? Who's got the fastest typing fingers? General range of movement, strength, neuro. Completely agree. Including upper motor neuron, yep. Anything else? So if we say observation, is there anything you want to see or not see?
I guess if you were thinking inflammatory, you'd want to have considered that you've looked at the joints for
correct, and that's what we've just got.
Synovitis, nail changes, those kinds of things.
Yeah, perfect. Look for inflammatory signs, heat, redness, swelling, agree. I always look at how they even walked into the clinic room. Is there actually a tactic gait? Is there an antalgic pattern? How many people have walked normally into the room or into the clinic and then they drag themselves into the room and hardly can get on and off the bed? They're the kind of things I'll start to look at. How they, if they are undressing themselves, how they move in those kind of, I guess those softer skills. So again, exactly, you've put there as nails function, that kind of covers it. Hypermobility, that's kind of really the one we missed, and that might be something to question if they've, and again, sometimes you'll just see it on their range of movements and something to question in this case. Differentials, so what are we thinking right now? So bloods are normal, there is no inflammatory sign right now. What are people putting their money on?
Fibromyalgia.
Oh, throw it right out there. Yep, FMS. So widespread pain not meeting, and I'll pass over to Danny and Pete, not meeting the fibromyalgia criteria. Neuropathic pain, I think that would, it depends what obviously how they're presenting in terms of where the pain is, joint hypermobility or inflammatory arthritis, but we've said at the minute there's no hot, red, swollen joints. So Danny or Pete or both, can you explain when you mean widespread pain but not meeting the criteria?
I guess I wrote it, so I'll explain myself. Sometimes people have so obviously the fibromyalgia criteria is like a collection of symptoms. I think we come on to talk about that. But sometimes people don't quite meet like the exact kind of numbers to be able to officially call it fibromyalgia syndrome. So you kind of like people that are a bit borderline, maybe a bit under, that are definitely on the spectrum of having widespread pain. So then you would probably just refer to it as widespread pain. And at any one point, they may well be reevaluated and tip over into that, to that sort of category of more of a collection that would be considered fibromyalgia syndrome. Remembering that syndrome is just a collection of symptoms. So yeah, so they might not score as much on things like the fatigue or the trouble thinking or remembering or waking up tired and refreshed, but they might have lots of signs, lots of multiple areas of pain. So for this case example, that might be it. Did the patient have any of the wider symptoms? Tiredness, fatigue, unrefreshing sleep?
Yeah, they do. We will give her depression, headache, doesn't, that's why she struggles at work, because she's always tired.
Yeah. Oh, you've marked it out. Nice. Filled it in.
So this is actually from having heard painting before. This is something I do more now in primary care. One, to hopefully help the pain colleagues, but actually sometimes it shows the patient that they're being listened to. I don't know what other people think, but these patients that have come multiple times in and out of the clinic, saying, oh yeah, let's actually go through and then refer on. I found that this has actually been quite a good rapport building. What are your thoughts? If I go, Pete, do you use this in city care?
Yeah, sometimes. Often patients already, I said the majority of time patients have already been given the diagnosis, so we don't do a lot of actual diagnosing of fibromyalgia, but yeah, we might use it if someone's not been given that diagnosis yet.
So if we start, how would you manage in primary care? What would be the first kind of things to look at from everyone's perspective in different job roles? Go back 2 slides. Laura, what's your first go-to if this patient came into you?
I guess with a patient like this, first of all, I'd be thinking about sleep, and have they got good sleep hygiene? Are they getting kind of more than 6 hours sleep a night? And is there any kind of really simple things that you can suggest that might improve their sleep quality? Then kind of talking to them and signposting them to all the kind of meditation and mindfulness resources that are available. So just suggesting things that they could try from that perspective. And then kind of having a chat with them about their exercise levels. What are they doing? Are they doing anything? And then pain relief. So for someone like this, I'd always try to refer to AMP or GP to discuss neuropathic pain medication if they've not tried it before. Kind of.
So in this case, she's tried pregabalin, gabapentin, and amitriptyline.
Yeah. So I guess if this was a patient that I saw in primary care, I would try and give them that kind of basic information, ask them to go away for like 6 to 8 weeks and give things a go. And then if they came back and they still kind of were struggling or didn't seem to have made any progress with anything, then at that point, I'd kind of be thinking about a pain team referral. I'm not sure whether you guys from the pain team agree that that's the right thing to do, or whether you'd rather see somebody sooner. I always feel a bit like if we referred everybody that had widespread pain to you would never have the opportunity to see anybody because you'd be so flooded with. So I try to give people kind of the basics that we're able to first, and then see how they get on.
Yeah, I think that's exactly it. I think some people just want to make sense of the symptoms. Once they know what it is and they've given some tools, they can go away and do some quite good self-management stuff, and they probably don't need any other input. But then there are the people that are more stuck, got wider problems, wider impact on quality of life, wider social difficulties that may well need a bit of support and unpicking to kind of implement. But I think it's about that early sell of that the mainstay of managing their condition is self-management. Drugs play a teeny tiny part, and for some they make no difference whatsoever, for example like this lady. So actually it's around all the lifestyle changes, which as a society we're generally not very good at, but some people are willing to kind of take it on board and run with it. I send lots of links on like SMS or AccuRx to to understand their fibromyalgia more and look at lifestyle things. There's a Living Well with Pain website, which we can post in the chat, that's got lots of useful information where people could start to make changes themselves. And then if they felt stuck, like you say, Laura, refer along for some biopsychosocial support.
I'd be really interested to know how you guys explain fibromyalgia to somebody. That's something that I find quite difficult. So kind of once somebody has got that diagnosis, and then they ask kind of what is it, or why have I got it, or does this mean it's all in my head? Do you know how you kind of answer those questions well? That's something I'm not sure that I do ever so well.
You probably do better than you think.
Yeah, I'm sure you do. Definitely emphasize that it's not all in your head.
Agree on that.
I guess I tend to just, I keep it really simple, and I just sort of tend to say, it's what we think is it's a nervous system dysfunction. where normal sensations are perceived as painful. Essentially, that's often about as complicated as I go.
Yeah, I think I use dysfunction, dysregulation, and also that's why wider systems are involved, because it's not just your pain that's controlled by function of your nervous system. And I try to move away from the fact that it's this, like you say, moving away from there's any harm or there's any structural change in terms of something we can measure with a test or anything like that. It depends on the person as well, how much in depth you want to pitch your info. And I think you would have to judge on that based on, but I think in a clinic where you don't have very long, what Pete said is, useful enough. And then you can give them some reading and almost get them time to reflect. And if they need to come back for a bit more understanding, they can, can't they?
And this is where I wrote with my
No, go
ahead.
I
wrote with my FCP head is obviously if work is becoming a problem, the fact that we can do med 3s, it's do we need to make amendments? Obviously, we're trying to keep people in work, but is it because they actually just need a DSE assessment because it's a posture base or they need to be able to have moments to get up and get moving, the basics like that, but opening up that conversation and also using your social prescriber and health and wellbeing coaches. If you've got it in your PCN, that might be how we don't go to pain team straight away, but you've got someone who can provide those local support resources, just making sure you use your whole team. And I've just put, this is kind of the link I generally send out as well as pain management resources. Pete, you might have another one for City, but it just has some nice, easy links. And that's probably the one I do of opening up that conversation without the referral first. Or sometimes if I refer, I send this as well, saying you can start to have a look. And when you go see the specialist or see Danny, you are a specialist, then you've already got things that you can start to discuss or what resonated well, what didn't. That's personally what I do using that link.
You might need to unpick a little bit as well, just going back to the subjective, why is this person so adamant they don't want to go down the rehab and physio route? Have they had bad experiences there in the past, or what are their beliefs around what they need? Sometimes this type of patient, you just need a conversation and they just need to feel listened to and validated, and don't feel like you've got to jump in with loads of solutions, which is classically what we do as physios. Sometimes you've just got to sit, listen and validate and just have a chat, really.
I was just going to ask whether you run groups and what those groups look like. I know in Danny's service you have a fibromyalgia sort of education exercise group. I don't know much about it and what it looks like or how people access it, but I wondered, Pete, in the City, do you have something similar?
Yeah, we've got a few different ones. We've got a face-to-face pain management group. We've got a face-to-face fibromyalgia group, and then we've got a sort of combined pain management / fibromyalgia virtual group for those that can't get to clinic or don't want to get to clinic. And we're just in the process of relaunching our chronic fatigue syndrome group as well, which again will be virtual.
Yeah,
so those patients all need to be assessed first, and then once we've assessed them, we can signpost them to those groups. A lot of people don't want to go in groups though, but.
And I guess this is with this patient, so we've decided to refer to pain team. I personally on a referral form would put to consider a medication review, given they've tried a lot. What is it? Is that to optimize their medication or have an expert? But then also if it would be BPS, that's probably what I would do. What would you do as an APP in pain for this patient?
Nothing if they've already got a diagnosis of widespread pain. So if there was some uncertainty about their diagnosis, we do that. If they've not kind of had that whole overlook of everything, work up, look at your symptoms. But generally, if they've got a diagnosis, they will be triaged straight to see a BPS practitioner, biopsychosocial practitioner, because there's nothing necessarily for us to add. But it's two-way. If they see them and there's some uncertainty about some symptoms or some you know, because let's remember that a lot of these patients will have other musculoskeletal problems potentially, have had for a long time, some concerns about other symptoms, trying to make sense of those. But generally we don't, other than initial assessment, we don't do much.
Perfect. I'll hand over to Laura for number 2.
Okay, so case 2 is a 50-year-old male who lifted a suitcase after a long flight 2 weeks ago, and subsequently got posterior right leg pain, which is getting worse. They've described it as burning type pain, so we're thinking about kind of neuropathic type pain, and they're struggling to walk, sit and sleep. They do quite a physical job with some manual handling on their feet all day, so they're really struggling to be at work at the moment. Just wondering with this patient, what are the questions people would ask? What are the information you would want to know in order to make a diagnosis? So feel free to unmute yourself or write in the chat box.
Are the symptoms worsening, improving, staying the same?
Yeah, great, thank you. So kind of the history of the condition, obviously improving symptoms is always reassuring.
Neurological symptoms?
Yeah, exactly. So kind of a little bit more about whether there's any numbness, any pins and needles. See, the big thing with acute radicular leg pain, thank you, Jamie, just added it in here. So thinking about that kind of red flag screen. So particularly relating to Cauda-Equina syndrome, do you know whether in the last 2 weeks that chap's had any changes to his bladder or bowel function, any new onset sad anaesthesia? Again, it's all about the last 2 weeks. I know he has had his pain for 2 weeks, but if this was a more chronic presentation, you would still be kind of specifically asking about what's been happening with bladder and bowel in the last 2 weeks, and whether there's any changes to his ability to maintain or maintain an erection or ejaculate. So they're kind of important in your screening questions as well. So in order to kind of have done a full Cauda-Equina screen, you would need to ask and document those 4 areas. In terms of kind of cancer red flags, yeah, absolutely. So just kind of the constitutional symptoms, making sure somebody's not lost a significant amount of weight, that they're not feeling generally unwell, kind of history of cancer, thinking about their age. Obviously, he's 50, so he kind of is just kind of within that not so concerning age group. But if this is new pain that he's never experienced before, he's never had anything like this before, that might raise your index of suspicion. So I think there is some more information. Thank you, Desi. So thinking about whether people have had anything like this before, are they somebody that's always suffered from discogenic back pain with ridiculous symptoms, or is this new? Are they somebody who's had spinal surgery in the past and this is kind of a recurrence or a flare-up, or is this the first time that they've had kind of symptoms that feel like this? What the ratio of back pain to leg pain is. So in terms of thinking about whether this patient is appropriate for pain team management, somebody who's got predominantly leg pain, the pain team are often able to help more than somebody that's got predominantly back pain. So that kind of ratio of how much of the pain presentation is related to the leg and how much of the pain presentation is related to the back is really helpful. So moving on to the next slide, kind of thinking about an objective assessment. So always wanting to do kind of a neuro screen with these patients, and probably a straight leg raise and a brief functional assessment as an absolute minimum. If somebody's got significant strength loss or loss of reflexes, that's somebody you might be thinking more about directing to the spinal ortho team or your kind of MCAT service rather than to the pain team. But if somebody has got symptoms which are predominantly pain related with a normal neuro assessment, then I think that's somebody who the pain team definitely can help and would be interested in seeing. So kind of thinking about differentials for this patient, probably thinking some kind of low lumbar radicular pain, any other kind of differentials that people would consider. Thinking like we don't want to rule out things like a GTPS with pain referral down the leg, a piriformis syndrome, you know, other things that could cause leg pain, which again the pain team might be less interested in seeing.
I put on there like a vascular presentation, thinking outside of our box of our systems, obviously.
Yeah.
Unusual, but not impossible. I guess that would change depending on what we saw. You know, if there was redness, swelling in the leg, whole leg, we'd start to have a different thought. Again, unusual, but just remembering with our NATH is thinking wider in that first presentation.
Yeah, I guess particularly if somebody's got kind of cardiovascular risk factors, if they've been a smoker, maybe if they're overweight, if they've got like cholesterol issues or high blood pressure, then that would be even more kind of at the top of your list.
And I guess this guy'd been on a flight, hadn't he? Been on holiday?
Yeah.
So I was thinking that, did he have a DVT?
DVTs, yeah, really important to rule that out. Yeah.
One thing I did put after Laura said it is the getting it right first time. So there is like a checklist of if it's less than 2 weeks, exactly what Laura said, and almost like bladder and bowel, it gives you quite a nice guide of what to do or when to seek onward help. So that is in the chat as well.
Yeah. Perfect.
If people haven't seen that or not used it, I would encourage you to look at it because it's really quite helpful for decision making. If you're seeing people in, you know, with potentially in this situation.
Okay, great. So in terms of management, if somebody saw this patient kind of with 2 weeks of this kind of pain, somebody who's potentially stressed about their ability to continue working, what sorts of things would you be considering for management?
Med 3 for work.
Med 3 for work, yeah. So kind of modifications to their role. Potentially they can continue to work as long as they're doing kind of no heavy lifting, no manual handling, no long drives maybe.
Well, it's even having a look at safety to drive, that if someone has got almost like numbness or weakness in that leg, I've had to have those conversations before. Are you actually safe to make an emergency stop? So thinking of, again, that bigger net of what is your responsibility.
Yeah, really good point. Is somebody safe to be driving? Yeah, definitely. Kind of thinking about pain relief for these kind of patients. So again, are they getting a good night's sleep? Have they got sufficient pain relief that they can kind of mobilize and walk and perhaps do some early exercises? We know that analgesia in the long term probably doesn't help back pain, but in the short term it can be really helpful. So considering kind of neuropathic pain medication potentially as well for these kind of patients. So kind of education and reassurance. I think sometimes in these kind of acute phases, people are in so much pain and they feel like it's never going to get any better. So I think that reassurance to know that 80-90% of people will get better by themselves. They're not going to need any kind of injections or surgical input, that it will get better within 6 to 12 weeks. Obviously safety netting, sort of simple physio advice. So I still give out extension exercises and kind of neuromobility exercises to patients like this, encourage them to walk more and sit less. I'm not sure if any other physios in the group do give the same advice or whether they give different advice.
Well, yeah, definitely keep it active.
And I also think we forget that, like physio, although they just provide a nice, I guess, somebody to keep an eye on things as it resolves itself over time and manage the fact that then they don't get all the secondary problems of not moving or being avoidant or etc. etc. So, you know, although it might not, you know, it's another way to help somebody manage through that time potentially. You know, keeping a watchful eye as they get better.
So I guess my question now, which I'll pass to Danny or Pete, is how long would you want to wait before a patient like this was referred on your acute radicular pain pathway? Normally, I wouldn't refer somebody before 6 weeks, but is that about right time, or would you be happy to see people sooner? And also, do you both have an acute radicular pain pathway? Does City have one as well?
We've got a spinal pathway, but it's not necessarily specifically acute radicular. I mean, it depends on your level of concern. If you're worried, then you could refer through straight away. But if you're happy with the presentation, happy that neuro's fine and there's no red flags, then yeah, probably sit on it in primary care for a bit longer. But if you referred that through to us, no, that'd be absolutely fine for us to accept.
So I think with this patient, we're happy that neuro's fine, there's no red flags, but pain continues to be a problem.
Yeah, so in that instance, I think, and this might be where there's like nuanced differences. Obviously, we've set up an agreement where only FCPs can refer on this acute radicular pathway to PICS pain. So that would be people with a normal neurological presentation. Obviously, if you were thinking there was any concerned abnormal neurology, then obviously that's going to go through the MSK triage service or to Spinal. That's not us. But if we're thinking that it's the pain that's really intrusive, but we would need to see that they've been optimized for medication, and also that they've given some time. I would say a lot of the people that do come through on the acute radicular pathway end up being better by the time that they get an injection. So it's remembering that, and it's being able to use that information with them. Sometimes they feel like in the height of it all, they need a plan, which means they got an injection or something. But actually, majority of people, it seems to resolve by the time they get to us. So I think the longer you can let them wait, the better.
I think the challenges I've found is obviously you want to give it some time before you consider an MRI, because it is like neurological is fine, but pain is the issue. And I think that's what delays getting in the acute pathway, is because to get an MRI from where I am in South Notts, we could be kind of a month to 2 months before I even get a report back. One thing I have done is, when you said about that pain optimization, is put the NOTS APC guidelines as well as the prescribing guidelines. So even if you're not a prescriber, just be aware, because that might help your hand over to a GP of what could be the best, not just throwing naproxen at people.
Yeah, exactly. And I think you're right. Obviously, if on the acute pathway, we obviously want people to have had a scan that correlates with your finding. But you're right, that in itself creates a time period of which by the time they get to us probably are considerably better anyway. So it doesn't end up being much difference between sometimes referring acutely, i.e. in the first 8 weeks or so, versus when you can refer to our service, which is 12 weeks anyway without a scan. So it's just remembering that. Obviously, they will wait longer for an appointment on a routine, but you could refer on an urgent at that point. So yeah, sometimes I know it's just trying to get, you end up taking on board some of the patient's distress yourself, trying to get through, book as many things as possible to try and manage them. And that can be hard, because obviously they can just keep booking back into your diary. I'm sure people have had that situation. I've definitely had some acute, radicular pain every week. They've booked back in because they're not coping.
Sorry, we've got a Pete question in the chat. Is there radicular? Sorry.
Just refer to Mosaic, Jamie.
Perfect. And the next slide is basically what we talked about, this getting it right first time pathway. So kind of for different spinal pathologies, it's got this almost flow chart, but then there's also like a click through. Has your patient had acute back pain, yes or no? And it will guide you to then which pathway to follow. So as Danny said, just have a little play with that website. And then, that is the little tick box. It looks like that. And then I quite regularly use text. I give out Cauda Equina cards. to probably when we talked about safety netting, I would always say I'd rather have it not need it. I've got no suspicion at the minute, but send it out in any medium you can. Does everyone agree on that?
Yeah, biggest part really for primary care is the safety netting of these patients. So just getting into have that somewhere where it's easy to send. Or
yeah, and I think having it written down that you've sent that written information via Accurix and it being recorded in notes is really important. The NHS spend more money every year on legal cases related to cord requirement than they do to anything else. So the documentation around it is really, really important. There's also a really good video by the MACP. I'm going to find it and pop it in. They've made a 2.5 minute video infographic about when to be worried about serious back pain, which can be also, I send that out with the cord recliner warning signs card.
And one thing I've been doing, I don't know if other people as well, I've got a lot of patients that need interpreters, and there's actually on the MACP a lot of these cards in different languages. So given this is quite a serious thing we talk about, I actually just bring it up in Farsi, Hungarian, whatever language I've got in front of me, and then I say, point to me if there's any, and then obviously it correlates to on an English one. So sometimes even translators are like, I don't know how, that we can lose in translation. So it's just consider going on that MACP website and using them in that language and sending it in both, and then you're covering yourself again in that legality aspect. Perfect. So Danny, handing over to you. Patient 3.
Thanks. Okay. So this case is 85-year-old male. He's got back pain. He notices it when he walks. If he sits down, it helps. If he stretches up or reaches up, that seems to give him pain. No history of trauma and no leg symptoms. What else would you like to know?
So does he get complete resolution when he's sitting or lying?
Yeah, so kind of behaviour of symptoms, definitely. Any other thoughts? This was your patient in clinic?
The shopping trolley signed and they feel better when they're pushing the trolley around the supermarket.
Yes, it's slight forward flexion. Yeah, so again, you're trying to establish, what they do with their spine. Does that make any changes? What about some of the other things that are more pertinent maybe to his age and obviously first time you might have met him?
I'd look at time frame. So are we talking weeks, months, years, progressive nature?
Yeah, really important, because I guess if this was a first presentation in an 85-year-old, again, that's one of the things that would initially raise our index of suspicion, because he's older. It's not to say it definitely is then a serious pathology, what we think about that. And I guess thinking about his past medical history. So has he got anything else in his past medical history that would make us more worried? Previous history of cancer. Does he have prostate? Things I would probably want to know with this guy, does he have any prostate symptoms? So he's not said any leg symptoms, but I'd be keen to know if there was any lower urinary tract symptoms, whether he'd previously be on PSA monitoring or anything like that. And like we said, nature of symptoms all help us to decide on whether there's a mechanical picture here or not.
And then any groin pain versus prostate check? It's just gone in the chat. I guess it's just ruling out that hip's not a culprit.
Yeah, exactly. So we've put leg symptoms, but being specific, any groin pain definitely would help, wouldn't it? If they got a degenerative hip actually. And prostate check, yeah. So to look at, I think the key things are very similar with all these patients, probably in your FCP clinic, because you're just trying to get a general basis of where they're at. Definitely their mobility in their lumbar spine, because that might be a really key one to help decide on what might be causing their pain. Hip range of movement, as we've said. And if indicated a neurological exam, I mean, this chap doesn't have any leg symptoms, any nerve symptoms. So certainly not necessarily needed. Sometimes for completeness of dotting the I's and crossing the T's and almost having a baseline, it's sometimes nice to do if you've got time, but I don't think you'd be criticised if you didn't have that without leg symptoms. And
this is someone I might do more upper motor neuron with, just with the age as the factor, actually asking, are you clumsy? Are you tripping, stumbling?
Yeah.
Something that might seem innocuous of, oh, it's just age, when actually it could be our biggest flag.
Yeah. But if they've not offered it up, or there's one or two signs when they're talking, or, you know, when you see them walk in, you know, there's a few clues that you think, actually, they're, you know, not doing so well with their balance. Then you start to think about, yeah, actually, you know, myelopathy presentation or something like that. Definitely. And again, like the other cases, establishing if there's any caudal equine symptoms along with your assessment, obviously.
Any other differentials? Or what is everyone thinking?
I know there's a lot of people sitting there. They definitely know what they want to say. Come on, yeah. Offer it up. Giving people, someone's typing, giving people a chance to type. Yeah. Yeah. Some of the common things we're thinking about this older chap. Has he got some stenotic back pain? Has he got degenerative disc changes, spondylosis? Yeah. And I guess particularly for me with this guy, is he actually specifically got kind of facet joint pain. That's with my little pain hat on that I might do. Particularly with the fact of, you know, he doesn't really have the claudicant leg pain. So, but you obviously can get stenotic changes without leg pain, which is great for the patient because then they've not got that horrible claudicant leg pain to go with it. And the reason that I think the way I would approach this guy is that depending on what you're thinking, you can offer him. The leg pain bit's a really important bit because there's much less to offer if there's no leg pain from a pain management perspective. So yeah, and I think that we'll come on to talk about injections. But in terms of management, obviously, someone with 85, depending on comorbidities, you definitely want to go down, you know, particularly if there's no concern in neurological features, you're happy there's no red flags, this is very much mechanical, degenerative changes. Yeah, definitely lots of education and rehab about managing that. Exercise can really help. All the other modifiable risk factors, keeping on top of those. Maximising his analgesia. And then probably once tried all those things, injections can be an option. But again, without leg pain, there aren't options really for stenosis. If we were thinking there was a definite facet joint arthropathy, then there are branch blocks, medial branch blocks diagnostically you can do, which might precede them to have radiofrequency ablation. But the general, I don't know if you find this, Pete, I would say the general outcomes for those are pretty mixed. Often more. I think that's putting
it politely. Yeah.
Up on the poor side, you wait a long time to get both bits in our service, probably best part of a year. And then generally the conversion rate of actually people having good quality improvement is very slim. So generally we've decided as a service, generally don't refer for those, you know, specifically put the patient's hopes up that that's what they're going to get, because we would always try and sway them to, like any other degenerative condition, trying to manage it with lifestyle stuff and exercise and pain relief. And then it's thinking about, sometimes we get requests for doing injections for stenosis, so they might have scanned and found stenosis, but when you see the patient, they don't really actually have any leg pain, so they're not really symptomatic of the, you know, in terms of the leg pain. So it's just remembering what really, being clear about what you're asking for when it comes to injections, if you do, and where is their pain. And actually NICE guidelines say don't offer caudal epidurals in people that have central canal stenosis. So that's what you need to think about your differentiation as well. Is it central canal stenosis or foraminal or lateral recess stenosis? So if they've got bilateral symptoms and they've got very much claudicant leg pain from central cord stenosis, NICE say don't offer injections, but they might not be a surgical candidate. They might not want to go down the surgical route, which is fair enough if they don't need to. So then I think we do them. You know, we are in that. Sometimes we do have people that will have them because that allows them to have a good quality of life, maybe be on less nasty meds. I don't know if you find the same with your service, Pete.
We can't do caudals anymore. They've been decommissioned a few years ago. So it's
so
medial
you're
branch
good.
blocks.
You've got a hard line.
Yeah, absolutely. Yeah, we got no choice.
We've got I'd say a bit of flexibility to do them, but certainly not for back pain. That's a definite no. And maybe occasionally for those with claudicant leg pain that maybe aren't a surgical candidate or really, you know, don't want to go down that route. We would generally opt for more of a transforaminal epidural nerve root block to be more targeted if they had horrible neuropathic claudicant leg pain and you weren't thinking of a surgical target. So yeah, it's just worth thinking about that before you refer, because we get a lot of people asking for injections, but actually by the time you had a conversation, they're not really probably suitable for them. And NICE guidelines are helpful in some respects about what is commissioned and what isn't. And obviously, as Pete said, there are nuances between services. So sometimes knowing your local service is obviously useful.
And I guess any message from either of you of, I guess, things that you have to do, like we said about setting expectations. Is there anything else from a referral perspective, patient management outside of injections, from both of you?
Don't know really. Other than just, I was just gonna say, don't get your patient's hopes up that there is a magic injection out there, because generally they're average at best. You might get a month or two of relief. They do say that radio frequencies can give relief up to a year, but I rarely see that. So again, like Danny said, it's, you know, lifestyle factors, exercise, rehab, those kind of things.
And then we added some additional, because we had some questions before about neurodiversity and chronic pain. So I'll just hand over to Danny on what you do differently in relation to, I guess, the mental health and neurodiversity side.
Yeah, I mean, I guess this was just a few thoughts from myself, really, which might make sense to, you know, probably what people are already doing. But obviously thinking about the relationship between people's mood, mental health, previous mental health, and that often it's a bi-directional relationship between pain and depression, and that's well established. So those with depression can often go on to develop chronic pain. Those with chronic pain often have depression as a secondary impact on their quality of life and functioning. So it's remembering that. And obviously we're now certainly, you know, in primary care, we've got wider access to mental health input, haven't we, earlier on? So if you're detecting that, that there's opportunity for you to signpost to your mental health OTs if they sit in there, or if you have health and wellbeing coaches in mental health. Thinking about kind of, you know, in terms of my comment around neurophysiology, neuroinflammation, that's more around thinking about, you know, why there's that bi-directional relationship on a kind of physiological basis rather than just impact on quality of life, functioning, kind of BPS bit. I guess this is the bio bit. Thinking about the role of what stress and anxiety do on your physiological responses. So they increase our muscle tension, increase our pain. People in pain often breath holds. There's all that sort of stuff that you can often pick up on, but you don't always get the opportunity to delve into that stuff. I'm mindful that in 20 minutes, that often is the latter thoughts, and probably is then more left to, you know, wherever you refer on. Thinking about, I think a big thing for our patients is their resilience and support networks. I think the people that don't do so well, we know, is because maybe they have a bigger strain on their day-to-day life. Maybe they don't have a support network. They have complex social situations. So don't forget the role of social prescribers can be really helpful. And I just put the NOTS Talk Therapies website for like self-referral to IAP type services, psychological wellbeing services. you might have something else to say, Desi, on mental health OT front, because that's, you look after those guys.
Yeah, so it's just in some PCNs you've got mental health OT, so similar to first contact physios, anyone with a mental health concerns can see the OTs, and that's where sometimes they can do that short piece of work, or again refer on as needed, be it if stress is the driver of the pain, that's where we can do all the beautiful rehab as physios, but if we're never getting to the core of it, and that's sometimes making sure you get the right person. In some PCNs we've got mental health, health and wellbeing, so I know they're in Nottingham West and Byron at the minute. So it's just making sure you're using your other R's staff. So it might be that you can identify that support network is a concern, and that's where in 20 minutes it's better placed with them as opposed to in your appointment. What can you get value? So I think that's where this is just to make you aware of what's out there and who can do more work.
And I guess, I don't know, and this might be different depending on your PCN, but in people that are really complex, I think I would definitely bring them back sometimes if you felt there was value in having another appointment to be able to sort of unpick some of this. Because we know sometimes that those early conversations or help with that can really then help the buy-in. Obviously, that might depend on the model that you work in, but I definitely would bring people back. I wouldn't set that precedent to try and get potentially all of that done in 20. I think really the 20 can be largely around ruling out your red flags and knowing, you know, where you're at with it. But the wider stuff can take some time. So it's okay, I think, to acknowledge that you won't get all that done in 20 minutes or 30 minutes or whatever you get.
And that's where I think more case too, with that like acute radicular pain. Sometimes I can't even test because they're so painful, and it's more of a pain inhibition than a true weakness. So I'll say, let's optimize your pain, then bring you back. And actually, yes, their neuro is completely normal, obviously with a lot of safety netting. But sometimes it is that reassurance that they're coming back to you and you've done something to make them better.
Yeah. And sometimes I might do a watchful wait or say, come and see me in a few weeks, so that you then maybe avoid an unnecessary referral, and but they know they've got someone to come back to just to sort of see if things have improved or haven't deteriorated. And then I made a note about neurodiversity and chronic pain. It comes up a lot, obviously in our pain service, and you may all have experience of sort of meeting more and more people who maybe are more aware they have a neurodiverse diagnosis, or they're waiting for a diagnosis of of being neurodiverse. That we know that there is a physiological effect on their amplification of their central pain system. So we do see a lot of people who may have been diagnosed with autism spectrum disorders that have maybe more widespread pain or difficulty with their chronic pain. And I think I was trying to think about this maybe as also thinking about how they might express pain, but also their pain experience, what it means to them, like we would with anybody. And in Nottingham, we have NATH, so our chronic pain service, we have links, cross kind of working links with them. They're our neurodiverse kind of assessment service. So we link in with them to sort of share best practice and support each other. We have a lot of people, probably crossover people in our services, that will also have.
What I've done is I've just put in the chat. So what I learned from NEST, the Neurodiversity Specialist Service, they said about getting like easy read documents. So I've just put an example, and this is just one I found online, of how to explain pain that you might not be able to in your assessment, but like Danny was saying earlier, going away and reading material to find out a bit more, to know what to ask next time. I know they do a lot of like safeguarding, so if there's a specific topic, just write easy read and that topic, and that might just help your patient have that understanding. And we were talking at the beginning of this chat that sometimes are people aware, is it pain or is it like DOMS after the gym? Are they I think that's what you meant by the expression of pain, of what is true structural or a different sensation.
Yeah, and I guess what it means to them. And I think using their language and being able to tune into that's really important, because that will allow them to feel like they've been heard.
Then more just to round up, so obviously Pete as well, the differences in your service about what the pain teams can provide, I guess what you want to hear from clinicians, be it in referrals, things like
that. I guess the mainstay of what we provide is obviously assessment and then signposting, hopefully to our groups, or if not, it's, again, like we said before, providing lots of information, trying to get people self-managing as best they can. We can do a few one-to-one assessment, one-to-one follow-up treatment sessions, but we're a very sort of assessment heavy service, so it's very much about just kind of getting people in, getting them assessed, and then trying to signpost appropriately. We don't tend to have a lot of sort of one-to-one sessions. What do we want to know from you guys? Just ideally that you've just done all the workup. We do have to still do quite a few diagnostics ourselves, which really is a pain service. We shouldn't have to. And I'm not criticizing any of you, but this is just the way it is. So just make sure you've done as much workup as you can before referring the patient into us.
Yeah, I think I'd echo that. Definitely from like a, you know, in terms of like how the pain service sits, certainly for mid-knots, South Knots, Rushcliffe and Bassetlaw, we do majority of our work similarly is the biopsychosocial approach stuff, but that can be done one-to-one for people or via groups. We have a Living Well with Pain group, probably people that are probably have more difficult changes to make, and the Moving On with Pain group are probably a little bit more ready to get going. And we also have a young persons group, which has won an award. So that's people who are like in that, you know, late teens, early 20s, specifically. We offer some CBT within the separate to the BPS for specific pain-related issues. So anyone that's maybe more wider mental health issues, they would definitely need to have their therapy within the mental health services. But specific issues around their pain, we have Caroline who does CBT work. We have wellbeing practitioners who are a bit like health and wellbeing coaches, so they might do extra work, follow-up work around getting people into physical activity. Obviously, medication, often a lot of de-prescribing, I would say, is what we do in our service, taking people off opioids and gabapentinoids. And
off injections if we can.
Yeah. And then diagnostic stuff, a lot of trying to sort of, you know, I think the classic is people have had pain for a long time, seen lots of different people, but still feel like they can't make sense of it. So it's a lot of assessment stuff, and some of the workup maybe that hasn't been done, and consideration of injections. But as I put on there, increasingly fewer options really for this. I think that will continue to get less and less over time. There are still a number of people that have historic injections that we've inherited from other pain services that are on repeats. As of yet, they can still continue, but we try to sort of get people away from those. But that's a hard slog, I would say. Mm-hmm. Sometimes it's better for them to have never had an injection. So remember that. Because I often say to people, well, if you have this and it improves for a little bit, then you're going to want another one. And then if you're in your 30s or 40s, where do you go with that? Plus, if you're having a steroid-based injection, we know there's some accumulative effect of steroid over time, potentially locally. So there you do have to sort of I always try and sell it most negatively. And it's amazing how many people then say, actually, no, I don't want that. So really sell the risks and really sell the fact that it's, won't necessarily work. And then what you're going to do if it comes back.
And then just a question in the chat. What are the most common reasons for pain clinic to bounce patients back into primary care, or is that just case dependent?
Not enough information on the referral, I would say, is the biggest thing. Because it's really hard. So the way we triage is that anybody in our team does triage, but there isn't a single point of access. So we triage to different areas. So they'll either go straight to BPS, straight to see a consultant for a few people if they have complex medical problems. Forgot to add them on or to APPs. So the more information we have, and we obviously boxes to tick, but the more information we have about what you think this patient needs, the easier it is for us to put that patient within the right appointment at the first time. Now, I don't always get it right, obviously, but and try not to copy and paste your notes. I think that's my biggest bugbear, because then I got to read through everything. But I just really want to know 2 or 3 key points and about what you're thinking this patient needs, and then we can take it from there. But if you get a full history, it's really hard to make sense of it. That's my thoughts. You might have some separate ones, Pete.
No, absolutely. Yeah, no, nothing to add there, really.
Can I just quickly ask, I'm really aware that we're coming to the end of the session, but in terms of like suprascapular nerve blocks or genicular nerve blocks for kind of those patients who aren't fit for surgery, is that something that you guys do? Are you happy for us to refer? And also coccyx injections or sacroiliac joint injections, are they something that you still do?
They are still commissioned, yeah. I'd say most of our suprascapular nerve blocks and genicular nerve blocks come from orthopedics when they, aren't a surgical candidate. So we don't see many, I wouldn't say many come from primary care, but if you feel someone's been overlooked, just ask us. That's the best thing to do. See, we don't do many of them, I must say. Coccyx, yes, we do, and sacroiliac joint we can still do, but they're all, those joint injections are just because they still considered a joint and they can't be done in primary care. I imagine it's a matter of time before they're not done, but for now. Yeah, and I think, to be honest, sacroiliac joints really typically would do diagnostically first, because how many people have true sacroiliac joint pain is very, very few. So it's remembering that.
Yeah. And regarding the nerve blocks, you were saying you don't do very many of them. Is that just because not many get referred through, or is it because they're not super effective either?
Which ones? The suprascapular nerve blocks and the genicular nerve blocks?
Yeah.
Yeah, I think mainly most probably have surgery. And yeah, again, it's very hit and miss. Very hit and miss. Because you have to remember the wider thing. So a lot of, if they've got lots of central sensitivity and central driving mechanisms of their pain, genicular nerve block, it's not going to address all of that. So yeah, I think it's quite variable, I would say. We don't have many people. I don't know what your thoughts are on that, Pete.
We get a few. I would say genicular nerve blocks are particularly unsuccessful. Suprascapular nerve blocks probably do a little bit better. Our consultants get quite frustrated with referrals from orthopedics a lot of the time. You might get someone post total knee replacement with residual pain, and the consultant's asking for a genicular nerve block, which is just not going to be effective, but we still get those sorts of referrals. But yeah, they're not. Yeah, they're sort of increasingly less common, I suppose, that we're doing these things.
Yeah. And most of the time, the ones I've seen have just missed all the basic stuff. They might have just ended up straight in orthopedics and never really had any of the good stuff. The education, the good assessment, the lifestyle stuff, all the modifiable things. They just seem to have missed out that bit.
It's very easy to jump straight to the injection, isn't it?
Yeah.
Yeah, we sort of forget about the rehab in between.
Yeah.
So I'm just very aware of time. Thank you very much, everyone, for your time, and especially Danny and Pete for joining us and sharing your knowledge on your services. I think the take-home message is make sure you use your whole team, your whole R staff or your GP practice team, the 4 referrals to the pain team, and if you refer, make sure you tell them what you want and write a good referral. So
save you having to do it again when we send it back.
Hopefully this has helped. Any further questions, then please get in touch with us. You will get the slides, and at a later date the recording will come back out so you can watch back if there's anything else. So Pete has just put in the chat for Mosaic.